Hello students, this is Perio, Chapter 20, Lecture 1. Radiolucent means that the structure is easily penetrated by X-rays and appear dark gray to black. This includes the pulp, the periodontal ligament space, periapical abscesses, bone marrow spaces, and bone loss and bone defects. Radiopaque structures absorb or resist the passage of X-rays and appear light gray to white. This includes metals, such as amalgam, some of the newer composite restorations, enamel, dentin, and compact or cortical bone. Radiographic identification of the normal periodontium. To recognize disease, the clinician must recognize the normal radiographic appearance and anatomy visible on radiographs. You must be able to recognize alveolar bone, cortical bone, lamina dura, periodontal ligament space, and cementum. See the images on the right for more information. The crest of the alveolar bone is normally 2 millimeters apical to the CEJ. If the coronal bone level is within 3 millimeters of the CEJ, it is considered normal. It is difficult to detect bone loss on radiographs if the bone loss is less than 3 millimeters. The crestal contour is a good indicator of periodontal health. The contour should be parallel to a line drawn between the CEJs of adjacent teeth. The surfaces of the bony crests should be smooth and covered with a thin layer of cortical bone. They are seen as a thin white line on a radiograph. When the CEJs of adjacent teeth are the same level, the crest of the interproximal bone will have a horizontal contour, as shown on the radiograph and illustration to the right. Angular or vertical crest contour. When one of the adjacent teeth is tilted or erupted to a different height, the crest of the interproximal bone will have a vertical or angular contour, as seen on the radiograph and the illustration to the right. The crest of the interdental septa between posterior teeth should be rounded or flat, and between anterior teeth should be thin and pointed. The lamina dura is a thin layer of dense bone that lines a normal tooth socket. It appears as a continuous white line around the root of the tooth. Radiographically, it is continuous with the cortical bone layer of the crest of the interdental septa. The periodontal ligament space functions as an attachment of the tooth to the lamina dura of the socket. It appears as a thin radiolucent line surrounding the root of the tooth. A widening of the PDL space, as seen in the image to the right, indicates tooth mobility. Components of the periodontium that can be identified radiographically include the alveolar bone, periodontal ligament space, lamina dura, and cementum. Benefits of radiographs for periodontal evaluation. A periodontal assessment is incomplete without accurate radiographs. The benefits are that the radiographs illustrate bony changes caused by disease, tooth root morphology, the relationship of the maxillary sinus to the periodontal deformity, widening of the PDL space, advanced furcation involvement, periodontal abscesses, and local factors. Radiographic signs of periodontal disease will show early bony changes, horizontal bone loss, vertical bone loss, bone defects, and furcation involvement. Early radiographic signs of disease. You will first see fuzziness in the crest of the interdental bone, then widening of the periodontal ligament space, and radiolucent lines in the interseptal bone. Widening of the PDL space caused by bone resorption on either the mesial or the distal of the interdental crest bone is also called funneling. Interseptal bone changes, finger-like radiolucent projections extending from the crestal bone into the interdental alveolar bone, represent a reduction of mineralized tissue adjacent to blood vessel channels in the alveolar bone. The direction of bone loss is determined by using the CEJ of adjacent teeth as points of reference. Horizontal bone loss shows bone destruction parallel to a line between the CEJs of adjacent teeth. Vertical bone loss shows greater bone loss on the interproximal aspect of one tooth than on the adjacent tooth, as indicated by the white arrow on the radiograph to the right. A radiograph is a snapshot of an instant in time in the disease process. Radiographs reveal the bone remaining rather than the bone lost. Even though bone loss occurs on all surfaces, radiographs are not able to show the extent on the facial and lingual surfaces. Assessment of furcation involvement is not seen on the radiograph until the bone resorption extends past the furcation area. It is easier to see on the mandibular than it is on the maxillary. Maxillary palatal root appears superimposed over the furcation of the tooth. Furcation involvement often is greater than it appears on the radiograph. Here's an image of furcation involvement on number 19. Risk factors detectable on radiographs are calculus deposits, faulty restorations, and trauma from occlusion. Large interproximal calculus deposits may be visible on radiographs. Large facial and lingual deposits may be visible if there is severe bone loss on the surface. Ability to visualize on radiographs depends on the degree of mineralization and the angulation of the X-ray beam. Faulty restorations can cause gingival inflammation, periodontitis, and alveolar bone resorption, and they can be detected on the radiographs. See the black arrow pointing to an amalgam overhang on tooth number 30 on the distal. Faulty contours between the first and second molar restorations create an open contact that may cause food impaction. See the image on the right, the interproximal between tooth number 14 and 15. Crestal bone loss of 5 millimeters and greater may not allow optimum coronal visualization with horizontal bite wings. Therefore, vertical bite wings are indicated. For vertical bite wings, the long axis of the film is rotated 90 degrees, and a vertical bite wing adapter for the film holder is used. Here is an image. Vertical bite wings show more of the coronal bone than horizontal bite wings. A radiograph is only a two-dimensional image of the three-dimensional structure. Buccal bone can hide bone loss on the lingual aspect. Palatal root on the maxilla makes the furcation detection difficult. Radiographs do not provide information about non-calcified components. Radiographs do not show disease activity. They do show the effects of the disease. Radiographic examination is never a satisfactory substitute for a clinical periodontal assessment. Radiographs do not reveal the following: presence or absence of periodontal pockets, early bone loss, exact morphology of bone destruction, tooth mobility, early furcation involvement, condition of the bone on the buccal and lingual surfaces, or the level of the epithelial attachment. Early bone loss must first be detected clinically, not radiographically. Interseptal bony defects less than 3 millimeters are not usually detected radiographically. Facial and lingual bone height are difficult to evaluate radiographically. X-ray beam alignment may conceal the presence or extent of involvement in a furcation. Use of a furcation probe is necessary in determining the actual clinical involvement. See the image on the right, the white arrow. Crestal bone loss greater than 5 millimeters may cause the coronal bone to be poorly seen on normal bite wing radiographs. Vertical bite wings are more appropriate. In vertical bite wings, the long axis of the film is rotated 90 degrees to be perpendicular to the occlusal plane. Recap. Radiographs are an essential diagnostic tool in the diagnosis of periodontitis. Radiographs assist the hygienist in detecting changes in the periodontium. Recognizing limitations of radiographs and utilizing appropriate radiographic techniques will ensure the best possible diagnostic evidence. This concludes Perio Chapter 20, Lecture 1.